Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time, but note that all questions will be saved until the end of the webinar. We have allotted enough time to answer as many questions as possible. Today's webinar, Multidisciplinary Care in Acromegaly, Individualized Treatment Improves Patient Outcomes, is being presented by Dr. Maria Fleseriu, Dr. Justin Cetas, and Dr. Elena Varlamov. Dr. Fleseriu is a professor of medicine and neurological surgery and director of the Northwest Pituitary Center at Oregon Health and Science University in Portland, Oregon. Dr. Fleseriu has a long-standing clinical and research interest in the pathophysiology and treatment of pituitary and adrenal disorders. She is a frequent guest speaker at national and international meetings on treatment of pituitary tumors, especially Cushing's disease and acromegaly. She is the principal investigator in clinical trials and has authored over 150 manuscripts and book chapters. Dr. Fleseriu is president of the Pituitary Society, serves on the board of directors, and chairs its Physician Education Committee. She serves on several committees for the Endocrine Society, Pituitary Society, and American Association of Clinical Endocrinology. She is past chair of the Endocrine Society Guidelines Committee and the Hypopituitarism Task Force. Dr. Justin Cetas is an associate professor of neurosurgery at Oregon Health and Science University, chief of neurosurgery at Portland, Virginia VA Medical Health Center, and residency program director in Portland. He has an active clinical practice focused on the surgical treatment of pituitary and skull-based tumors and cerebrovascular disease, and he performs more than 100 pituitary surgeries annually. He uses a thoughtfully conservative approach dedicated to delivering outstanding neurosurgical care with an individual patient-centered focus. Dr. Cetas is one of few fellowship-trained, minimally invasive neurosurgeons in the country. Dr. Varlamov is an assistant professor in the Department of Neurological Surgery for the Pituitary Center and Division of Endocrinology, Department of Medicine of Oregon Health and Science University in Portland, Oregon. She has a special interest in neuroendocrinology, including pituitary tumors, acromegaly, Cushing's disease, growth hormone deficiency, post-traumatic and post-radiation pituitary dysfunction. Her research involves treatment and clinical outcomes in the pituitary disease. She has been a co-investigator in multiple clinical trials. She has published in peer-reviewed journals, book chapters, and presented at national and international meetings, including Endocrine Society and Pituitary Society. There will be a brief delay as we change presenters. And you should see on your end to accept. I can see your screen. Okay.
Hello, good morning everyone from Portland, Oregon. Thank you to PNA for giving us the opportunity to talk about multidisciplinary care in acromegaly. Individualized treatment improves patient outcomes. And I'm happy to be here with my two colleagues that we work most of the days, Dr. Elena Varlamov and Dr. Justin Cetas. These are our disclosures. I'm a principal investigator for several clinical trials with Chiasma, Crinetics, Ionis, Novartis, and Pfizer, and the research support goes to the institution. And I'm also receiving scientific consulting fee for these studies, and I'm a scientific consultant occasionally from Ipsen and Ono. The most important thing that we have to talk about acromegaly is why do we have a delay in diagnosis? And this would be very important when we're trying to improve outcomes. So you can see here, when we're talking about patients with undiagnosed and uncontrolled acromegaly, the delay and the latency of intervention will clearly result in increased comorbidities, and you're going to hear in details about all of these. Increased medical costs, and now it's an issue for a lot of other diseases, but for rare diseases might create even more of a problem. And unfortunately, increased mortality, though if we're diagnosing earlier and have the treatments appropriate, the mortality, and I'm going to show you some studies, is reducing back to normal population, and then I think it's one of the advantages over the last few years. We're also talking about decreased quality of life, and more important, the earlier the diagnosis, will be able to reverse some of the comorbidities, and some will not be reversible, but that would be important to determine which one. So the appropriate diagnosis and the appropriate treatment would be essential. Furthermore, and you're going to hear from several of us our own approaches, but what we are trying to and striving to do would be personalized treatment. We know that patients with acromegaly are diagnosed late and they have large tumors. And you are going to hear from my colleague what do we do about surgery, and sometimes it's hard to predict who's going to be improving. But what we're trying to do would be, out of all these patients on the left with persistent disease after surgery, stratified by their individual clinical attributes. So each of the patients are different, but we're trying to figure out how to guide their treatment based on comorbidities, disease characteristics, and I'm going to show you some data on that a little bit later, or biomarkers from the pathology itself that will tell us how to predict biochemical response. So ideally, we're not there yet, but out of all these patients, we're going to be able to have several specific groups, here determined by colors, that will tell us exactly when we should treat and with what we should treat. And what we're trying to achieve overall. So patients with acromegaly have symptoms due to the growth hormone excess, and some of them are due to the long-standing growth hormone, as arthropathy or neuropathic pain. This will induce impaired physical function. And then all of it will create psychological symptoms, from poor body image to depression and anxiety and cognitive dysfunction. And the patients are telling us more and more, and we pay attention with patient-reported outcome. And then the effective treatment that we also have to look, from the burden of chronic medication to radiation therapy that has some complications, including hypopituitarism, and then we have to replace the hormones. As you can see, the surgery is not here, because the surgery is actually what can achieve the best outcomes if we have control of the disease itself. Now, before we move to personalized treatment overall, I want you to point out that this is a study from Europe. We do not have direct data in US from larger studies, but it's also very important who is making the diagnosis. And as you can see here in this large European study, the diagnosis was made by endocrinologists in almost half of the patients, and a little bit about neurosurgeons and general practitioners and other specialties, very little. What we'll try to improve would be the diagnosis to be at least suspected and even made, hopefully, much, much earlier by all of these other specialties, that once we have a list of symptoms, to increase the awareness, and we're working towards that. So hopefully we can report in several years that we have much better data about that. And now we're going to move to treatment overall, and you are going to hear from our neurosurgeon, Dr. Justin Cetas.
Good morning. Once the diagnosis of acromegaly is made and a cellar or pituitary source for the elevated growth hormone is identified, then we start to decide what is the first step. The current recommendations is that patients who are good surgical candidates undergo transsphenoidal surgery. And most patients fall into that. In a small number of cases, the patient may not be able to undergo the small amount of risk associated with the surgery, and in those cases, pre-treatment with medical therapy is considered. This chart here shows the general flow. So we start up with transsphenoidal surgery for most patients. If there's remission, then we just check annual IGF-1 levels and random growth hormone levels, and then we consider additional studies to prove that the patient is still in remission. And then we obtain surveillance MRIs on a regular basis just to make sure that there is no recurrence. If there is persistent disease, if we were unable to take the bulk of the tumor out initially and we feel like we can get more of it out with a repeat operation, we will go back, and that's here. In some patients, we are unable to take the entire tumor out, and I'll show you some examples of that in a little bit. And that's usually due to the size of the tumor and its growth pattern and how invasive it is to surrounding structures. In some cases, complete excision of the tumor would be too dangerous. In that case, we would still proceed with surgical debulking because that provides benefits for medical therapy. One, it decompresses surrounding structures, and if you were having visual problems or something like that, and also it makes the medications more effective. There's several different medications, and which one is chosen depends on the tumor biology and the responsiveness or anticipated responsiveness. And it's only if we're unable to take the tumor out and the tumor is not responsive to these different medical therapies that we consider stereotactic radiosurgery or conventional radiation, as this has a high risk of making the entire pituitary gland non-functional, which has some consequences. So once pituitary source is identified for excess growth hormone, surgical treatment is recommended as a first-line therapy. Surgery can permanently restore normal growth hormone, even in cases where we don't get every bit of tumor out. It improves the efficacy of medical therapy and is essentially very cost-effective because it's a one-time treatment rather than, and if successful, eliminates the need for ongoing therapies. This is a summary slide showing recent studies and showing the remission rates after surgery. As you can see, if you have what's called a microadenoma, a tumor less than 1 centimeter, remission rates from many centers are quite high. They range from 100% to over 50%. As the tumor gets larger, the remission rates tend to go down as it's harder to get a complete resection of that tumor, but the remission rates are still good. They range from 26% at one institution all the way up to 80% at another. Factors associated with biochemical remission: size is probably the number one. The smaller the tumor, the better, because it's easy to get around it and preserve the gland and also completely excise the tumor. Less invasiveness is better. If the tumor crawls out into surrounding structures, it's hard to remove. The magnitude of the preoperative IGF-1 and growth hormone oversecretion are important indicators. Patients with very high IGF-1 tend to have a lower remission rate. The number of patients cared for at a pituitary center have been shown in numerous studies to improve outcomes and increase remission rates, and the surgeon experience. So the more operations the surgeon's done, the more he appreciates or she appreciates the nuances involved and has a better remission rate. The most common approach is called the transnasal transsphenoidal approach. This simply means we go through the nose, through the sphenoid sinus. We follow the natural air passages back till we get to the skull base, and that takes us directly to the tumor. In a small number of cases, we actually have to do what's called a transcranial approach, and that is when the tumor is very large and extends off to the sides, and we can't reach it through a midline or transnasal approach. This is a picture showing that it's a direct shot from the nostril, straight back, following the natural air passages till we get to where the tumor is. This is the sphenoid sinus, a big air cavity lined with mucosa. We remove that mucosa, drill off a small amount of bone, and then we are essentially looking right at the tumor. This is a schematic showing the NOTS grading system. This just shows the different growth patterns of tumors and then assigns a grade based on the pattern. The top one is a grade 0. This is a tumor that's confined just to the pituitary gland. These are these are small, these are easy to remove, and these have the highest remission rates. The grade 1, you have a much bigger tumor that's expanding the pituitary gland. Here it is, the gland in just a thin rim, and it's up to what's called the cavernous sinus, the structure off on either side of the gland that contains the carotid arteries, numerous nerves that control eye movement, and some venous channels. The grade 2, the tumor is starting to push into the cavernous sinus, making resection a little bit more tricky. And then as we keep increasing, we eventually get to the grade 4s where there's complete encasement of the carotid artery. These cases, it is very difficult to remove the entire tumor just because these nerves here off to the side are at risk of injury, which would cause double vision and potentially injury to the artery. These are MRIs showing that are examples of these different grade tumors. And then here on the right is what we would see during surgery using the endoscope. And as you can see, we can readily identify the important structures within the sella region. This is a video showing the removal of a greater than 1 centimeter tumor. And basically, you can see that we can identify the normal pituitary gland and readily distinguish it from the tumor. Here we are taking a sample to send to the pathologist. This is a curette. We're gently separating the tumor from the surrounding gland and dura. This covering is the dura. It overlies where the tumor is. The soft stuff is the tumor here. And the pituitary gland is up in this region. You can see a bit of the pituitary gland right there. And then with just gentle aspiration and curettage, as it's called, we can remove this tumor. Here we're opening the dura just a little bit more to allow us to get the remainder of the tumor out. As you can see, it's quite soft and easily separatable, or it's easy to separate it from the surrounding structures. That's the last little bit of tumor coming out there. We achieved hemostasis by putting that agent in there. And that's a little bit of the capsule. And there is the cavity. This is the back wall. There's no tumor there. This is the pituitary gland. And this is the covering, the dura overlying it. And there's no obvious tumor left. Here's a couple examples of our patients. This is a 60-year-old woman who's been in remission for more than 2 years. The image here on the left is her preoperative tumor, and you can see that it extends to the cavernous sinus, which is right here. These dark circles are the carotid arteries. The normal gland has been pushed up and off to the side. This darker area here is the tumor. And this is her postoperative image from 2 years later, and you can see that there's a little bit of pituitary gland. It's still functional down here. This is pituitary stalk, and these are the optic nerves. They're well decompressed, and there's no visible tumor present. Her optic nerves were pushed way up here. Her pre-op GH and IGF was 35.9 and 487, and that came down to 1.15 for GH and 83 for IGF-1. So very nice response. This is a second patient who had a smaller tumor, and it's located here with the gland pushed off to the right. Here it is 3 months post-operative. You can see a resection cavity here and some normal glands here. And then this is her scan 9 months later with resolution of that resection cavity. She was a young woman, had a more aggressive and secreting tumor. Her preoperative GH and IGF-1 was 35.9 and 487. 3 months later, it came down, but she was not yet in remission. And then by 9 months, with the addition of Fleseriu, it normalized, and she's doing very well. So now I'm going to hand off the talk to Dr. Varlamov, and she'll talk about the associated comorbidities.
Hi, good morning. Thank you for joining this webinar. So I would like to talk about the comorbidities in acromegaly, screening for them, and also how the treatment for acromegaly affects the course of these associated health conditions. So I will talk about cardiovascular disease, sleep apnea, bone health, colonic polyps, thyroid nodules, and metabolic disorders, diabetes and hyperlipidemia. So why do we talk about comorbidities? Why do we care? Well, that's because oftentimes we diagnose acromegaly late in the course of this disease. The average delay in diagnosis is 8 years. However, it seems to be shorter nowadays. And by the time acromegaly is diagnosed, a lot of patients will develop some degree of change in those organ systems. And we would like to catch that early so that we can do something to prevent those complications from progressing, or in some cases, even to reverse them. This is a slide showing our data. As you see, patients older than 65 have higher prevalence of comorbidities. However, even young patients younger than 30 years of age also have those comorbidities, including hypertension, diabetes, or impaired glucose tolerance. And they perhaps have more comorbidities than shown in this slide, simply because we have not screened all of them, because we think they're young and they may not have that. However, if we do more studies, I'm sure we'll find more associated disease. So first complication that I would like to talk about is cardiovascular, in particular hypertension. The prevalence of hypertension is approximately 30%, and it's thought to be due to retention of salt and water by the kidney. Interestingly, the diastolic pressure is elevated more so than the systolic pressure. So the bottom number tends to be higher than the top number. And the good thing is that hypertension is usually mild. However, we should not discount it, even though it's mild, because long-standing hypertension is associated with heart disease, left ventricular hypertension, myocardial infarction, stroke, and chronic kidney disease. Acromegaly also causes changes in the heart muscle. What's collectively called cardiomyopathy includes myocardial hypertrophy, diastolic dysfunction, valvular disease, arrhythmia, and even heart failure. The prevalence of myocardial hypertrophy, or increased left ventricular mass, is 11 to 78%, and this is a wide range, and you will see it for almost every complication. And that's related to the fact that the studies that were done evaluating the prevalence of these conditions were very different. The data were collected differently, and the populations that were screened were different. So that's why we see such a wide range. But still, the 78% prevalence of myocardial hypertrophy is alarming. Diastolic dysfunction, or impaired relaxation of the heart muscle, is also present in 11 to 75%. If left untreated, acromegaly can further affect it, and late in the disease, some patients will develop heart failure, which in some cases can be optimized, but in other cases can be very difficult to manage. Valvular disease is very common. And looking at different data, the prevalence is 20 to 87%. And that seems to be similar to the prevalence in general population in many studies, However, we don't know about the true prevalence of mild degree of valvular dysfunction, such as mild or trace mitral regurgitation or mild aortic stenosis. So we need more studies to actually know how common valvular disease is in acromegaly compared to general population. Arrhythmia has been reported to be more common in acromegaly. However, again, more studies are needed. And nowadays that we have improved screening and improved treatment, these complications seem to be decreasing in prevalence, and arrhythmia also seems to be similar to that in general population. So what do we recommend for patients who come to us with the new diagnosis of acromegaly? Everybody should get their blood pressure measured at every visit. Echocardiogram or ultrasound of the heart is recommended for everyone at diagnosis. And this is what we do to screen for that hypertrophy of the left ventricle, for valvular disease and heart failure. If the echocardiogram is normal and the disease is controlled, then the patient may not need to have a repeat one. However, if there are some changes present already and their disease is not perfectly controlled, then repeat echocardiogram is usually required. And when to repeat it, that can be determined either by the endocrinologist or primary care doctor or the cardiologist if the patient has one. So it can range anywhere between 1 and 5 years. In addition, every patient should be evaluated for risk factors such as diabetes, hyperlipidemia, and smoking. And it is very important to address those because they can also contribute to development of heart disease. In addition, some patients will require other studies such as electrocardiogram or EKG, which can sometimes diagnose persistent arrhythmias with normal heart rhythm, but not always, and therefore some patients will need Holter monitoring if there is still high suspicion for arrhythmia despite normal EKG. And again, some patients will need a referral to a cardiologist. It's very important to control IGF-1 and GH because that's the only thing that can improve or prevent progression of cardiac dysfunction. There's no treatment for ventricular hypertrophy per se, so we always need to address the underlying cause. And unfortunately, some changes may be irreversible, but in many cases, treatment for acromegaly will improve cardiac function and will improve blood pressure. The treatment for hypertension is the same as in patients without acromegaly. The next complication I will talk about is sleep apnea. It's also very prevalent, 27 to 88%, and it's caused by hyperglossia or enlargement of the tongue and soft tissue swelling in the pharynx and larynx, as well as thickening of the vocal cords and changes in the jaw, overgrowth of the jaw. Additionally, some patients has abnormalities in their respiratory control center in the brain, and they have a so-called central sleep apnea. The symptoms of sleep apnea are usually loud snoring, daytime sleepiness, and poor quality of sleep. And why do we care about sleep apnea? Well, it's associated with hypertension, cardiovascular disease, stroke, motor vehicle accidents, and poor quality of life. So it's important to diagnose it and treat it. And screening for sleep apnea includes questionnaires and sleep study or polysomnography. You may have heard of Epworth Sleepiness Scale, Stop-Bang Questionnaire, and some others. They assess how likely you are to have sleep apnea. However, these questionnaires have not been validated specifically for acromegaly. So doing just a questionnaire may not be enough. And this is why sleep study is recommended for all patients at diagnosis. Once the treatment is initiated and biochemically disease is controlled, the severity of sleep apnea usually improves. And in mild cases, it can be completely reversible. However, if it's more persistent and has been present for a long time and more severe, then some changes may not be completely reversible. Continuous positive airway pressure, or CPAP, is recommended for patients with sleep apnea, but in some cases, patients will use special devices, mouthpiece devices prescribed by their sleep specialist. If you're already on a CPAP at the time of acromegaly diagnosis and your disease is controlled in a few months, then your CPAP settings may need to be adjusted. Additionally, weight loss is recommended for everybody with sleep apnea, just in general, so it's also important to address that in patients with acromegaly. And finally, testosterone replacement is known to worsen untreated sleep apnea. And many patients with acromegaly have low testosterone or hypogonadism. So it's very important to assess for sleep apnea and treat it first before even initiating the testosterone, especially if disease is uncontrolled. The next complication is bone disease. So growth hormone and IGF-1 are important in acquisition of bone mass. That's important when we grow. And we think that, well, big bone mass, big bones may mean strong bones. However, that's not the fact. In acromegaly, patients have poor quality of bone and their bones are fragile. And we know that because we see increased prevalence of vertebral fractures in these patients. Oftentimes they're asymptomatic, perhaps most of them asymptomatic. We see them on x-rays. However, the vertebral fractures indicate increased skeletal fragility. In general, vertebral fractures are associated with other fractures, such as hip fractures. Unfortunately, we don't have the data on non-vertebral fractures in acromegaly. However, perhaps their risk is also increased. In acromegaly, the bone turnover is increased, and this leads to impaired trabecular microarchitecture. Additionally, some patients have calcium and vitamin D deficiency, which also impairs bone structure. Untreated hypogonadism and diabetes mellitus are also risk factors for osteoporosis and impaired bone structure. How do we diagnose vertebral fractures? Well, here you see two x-rays. On the right is a normal spinal x-ray, and on the left is a spinal x-ray showing so-called vertebral wedging. And that's what we mean when we say vertebral fracture. So we look at the height loss in the vertebra or changes in the height in the frontal part of the vertebra compared to the back part of the vertebra. And if we see a difference, this is what we call vertebral wedging. But essentially, it is a fracture in the mild stage, and that can progress and potentially can result in complete collapse of the vertebra. Unfortunately, bone density scans or DEXA scans are not reliable in assessment for bone fragility because bone density is often increased in acromegaly. And as you see here, this 62-year-old gentleman with acromegaly has elevated bone mass. His T-score is plus 2.2. However, he has vertebral wedging. He has those mild vertebral fractures. This is our data, again showing that osteoporosis is not common in acromegaly. Osteopenia is a little bit more common, but yet patients with acromegaly have fractures. Majority of them have only one fracture, but you see some patients have 3, 4, 5, and even 7 fractured vertebrae. Most of them are located in the thoracic spine, and the majority of them are mild. Treatment for acromegaly is very important to prevent progression of the fractures. However, despite control of the disease, 20 to 30% of patients will have progression of vertebral fractures on the X-ray. And what it means is that periodic spinal X-rays should be performed. We don't know how often We don't have the data yet, but general recommendation is probably every 2 to 3 years, depending on the initial findings and depending on other risk factors. Osteoporosis and acromegaly, if found, should be treated as in patients without acromegaly. Additionally, any contributing conditions should be treated, such as calcium deficiency, vitamin D deficiency, hypogonadism. And it's also very important to avoid glucocorticoid over-replacement in patients with adrenal insufficiency. Next one, colonic polyps. The link between elevated growth hormone, IGF-1, and tumors have been long suspected and proven in vitro studies. So growth hormone and IGF-1 promote cellular proliferation, differentiation, protein synthesis, and those processes promote tumor development. It has been studied whether or not acromegaly is associated with certain cancers. And we have the data that acromegaly and colonic polyps are associated. In patients with acromegaly, there is possibly also a high risk of colon cancer. However, the mortality from colon cancer is not increased. The prevalence of colonic polyps is 7 to 76%, again, depending on what study we look at. The prevalence of colon cancer is 0.9 to 2.4%. Some risk factors may predispose patients to development of colonic polyps and colon cancer, and those are age over greater than 50 years, male gender, family history of colon cancer, and also, interestingly, 3 or more skin tags. The screening for colonic polyps is colonoscopy, and that's recommended at least once at diagnosis. Depending on the findings, a repeat colonoscopy may be necessary within 3 to 5 years if there are polyps present, or if it's completely normal and disease is controlled, then the follow-up colonoscopy can be performed in 10 years, as in general population. Thyroid nodules are also very prevalent, 43 to 76%. And they're common in general population. But unlike general population, where the thyroid nodules are more common in women, in acromegaly, men and women have the same prevalence of thyroid nodules. The good news is that majority of the thyroid nodules are benign, and the risk of thyroid cancer in acromegaly versus general population has not been well established. Some studies have shown higher risk of thyroid cancer in acromegaly. However, it is possible that those studies have been biased simply because they were looking more closely at the population of patients with acromegaly, and they performed more close screening or frequent screening, and that's how thyroid cancer was reported to be more common. The screening for thyroid nodules is fairly simple. It includes annual clinical examination, palpation of the thyroid gland. If the nodule or thyroid enlargement is found on the physical exam, then the ultrasound of the thyroid gland should be performed. And if there are any suspicious nodules found on the ultrasound, then biopsy is recommended. And finally, I will talk about metabolic complications, diabetes mellitus type 2 and lipid abnormalities. So diabetes is more common than in general population. The prevalence is 16 to 56%. It is related to insulin resistance. The pathogenesis or mechanism of insulin resistance is very complex. And growth hormone is a hormone that opposes insulin action. Majority of the patients with acromegaly have mild diabetes, and as far as lipid abnormalities, the majority of the patients have mild changes in their lipid panel, and that includes in elevated levels of triglycerides and reduced levels of HDL or good cholesterol. Screening for metabolic complications is fairly straightforward, and that includes hemoglobin A1C measurement, fasting glucose or oral glucose tolerance test. An oral glucose tolerance test is often performed at the diagnosis of acromegaly. So majority of the patients already have their screening done when they're diagnosed with this disease. And lipid panel is another test that is easy to do. All patients should have these tests done at the diagnosis, and the patients with active disease should have them performed annually. And the final few words about metabolic complications is that patients who take somatostatin receptor ligands, and those are triatide, lanreotide, and particularly pasireotide, can develop hyperglycemia, and that's related to the mechanism of action of those drugs. So patients who are taking pasireotide, we watch them very closely with A1C measurements, and also have them check their blood sugars as well regularly. The good thing is that in general, control of growth hormone and IGF-1 improves diabetes and hyperlipidemia. And this is my final slide showing data from our institution, percentage screening rates for comorbidities. As you see, we're trying to do a good job and screen everybody. However, we're screening approximately 30 to 50%. And that could be that we're not collecting all the data, because sometimes it's hard to track what has been done and what has not been done. Patients who come to our center often return to local care with their endocrinologist after the pituitary surgery and after the first year of follow-up, and then they come back periodically. We usually tell the patients what studies need to be done, and we send letters to primary care providers. And then we try to keep track of that, but it's hard. So the screening rates are not what we want them to be. But what we see is that screening for vertebral fractures has increased over the last several years. And that's easy to do. Usually we do them same day as their clinic visit. So they just go to the radiology department and get their x-rays done. A1C and lipids are also easy to do. It's a blood test. However, we often rely on the primary care doctors to perform those. And polysomnography obviously needs special referral and scheduling, as well as colonoscopy. And echocardiogram, we try to do it same day as clinic visit, but we have to schedule that in advance as well. So it can be challenging, but we're trying our best to improve our rates, and I think we're moving in the right direction. So at this point, I will turn it over to Dr. Fleseriu.
So you heard about complications and how we're all striving, and we definitely need more awareness with physicians, with patients, and with specialty tertiary centers like us to improve the rates. And I'm hoping to see a perfect correlation between guidelines and actually what we do to be 100% if we do this webinar again in several years. In between, we're moving now to treatment goals overall, and you heard from Dr. Cetas about surgery, so I'm not going to focus on the surgery. We're neuroendocrinologists, of course, we're going to talk more about the medication, but what are our goals when we treat a patient with acromegaly? So we want to reverse the clinical signs and symptoms while preserving the pituitary function. Of course, we look at the control of GH and IGF-1 because we're endocrinologists, so we like numbers. With surgery or with other type of medications, we want to stabilize or reduction in tumor size. And is anything missing? I showed you a little bit earlier, but definitely from the guidelines to up to now, we have to talk more about patient-reported outcomes. Which medications do we have available right now? So you heard some of the problems we have related to comorbidities and medications, but overall, we have several somatostatin receptor ligands, octreotide, lanreotide, and pasireotide, and all of them work at the pituitary level overall. Now, can we predict who is going to respond. And you've seen that a patient that Dr. Cetas showed, for example, went directly to pastirotate, for example. He didn't get into too many details why, but I can tell you that that patient had a sparsely granulated tumor, for example. So clearly, we expect more response from one medication versus the other. We also use dopamine agonists. These are not approved for acromegaly in US, but sometimes for very, very mild disease or in combination, we're using cabergoline, not bromocriptine, and cabergoline has been approved for prolactinoma, so sometimes even for mixed tumors. We also have the growth hormone receptor antagonist, pegvisomant, that doesn't work at the tumor level, but it's stopping the growth hormone effect. It's an antagonist of the receptors. So overall, we'll decrease and normalize the IGF-1, and I'm going to show you a little bit of data, what's important for each of these drugs. So I said earlier that the type of tumor, and in our center, the large majority of patients will go to surgery. One, because we expect the high cure rate that we have overall. In addition, even in large tumors that we know that the tumor is in the cavernous sinus and is not going to be controlled after surgery per se, we're looking at surgical debulking. And we know, and there have been several studies, that if you have less tumor, you start from lower GH and IGF-1, we're going to see better response. So in addition to that, we get pathology. Now, that type of pathology, as you can see here, my direct treatment. So this was a study that we did now several years ago in our center, that the response to medication, octreotide or octreotide, they were on both of them, depended on the type of tumor and receptor. So if you see here, for sparsely granulated, if you had a tumor, yes, you can see some response. That was 30%, but definitely not everybody responded, as you would see with an adequate response. How about receptors? If you have no receptors, and we're routinely doing receptors here in the pathology, you are not going to see control. If you have the receptors, as you see here in blue, you'll see a high response. That's not 100%, but also it's nothing 100% in life overall. There are other markers. This was a study for lanreotide, but I'm sure it applies to other. And if you look on the left, you can see the correlations overall between males and females. This was a total group overall. But then look by gender. And as you can see, and we can talk why the males have been more responsive in detail if you have some questions, but tumor size, we know that if you have larger tumor, you respond less. And also the diabetes patients had lower response overall. If you're looking by BMI, and that's what's on the right here, this was not a prospective study, it was observational, but clearly if the patient had higher BMI, and the cutoff for this study was 30, the response rate was lower. And this is probably related to dose, that maybe they should have had been on a higher dose overall. How about treatment outcomes? So if we're looking, this was a study that I have presented last year now, that we looked at patients' reported outcome and what did they say that they were satisfied or not with their treatment. So these patients were all on injectable somatostatin receptor ligands. So if you are looking, 34% of patients reported that the treatment was somewhat inconvenient or clearly inconvenient. And of course, the scheduled injections and the need to travel and impacted their ability to make plans. But overall, with all these, 81% of patients reported being very satisfied, or somewhat satisfied with their treatment. Now, this was an initial studies, and there are more and more looking at patient-reported outcomes, what patients are looking into the treatments. Of course, as physicians, our main focus has been and should be on efficacy of all the treatments, but definitely for drugs that have equal efficacy. So we can say that we're looking at something that the patient will do better just because they are more satisfied. We have to look at both efficacy and keep in mind that patient-reported outcomes are very important because we need patient cooperation overall. We have data that the patients are lost to follow-up, not from US, but there will have been several studies from other countries, and I'm sure this happens in the US too. So maybe that has something to do with the dissatisfaction of the patients itself with the treatments that we have to offer. One of the newer drugs, and you heard a little bit earlier about it, it's pasireotide, that binds with higher affinity to the receptors type 5. And if you look here, comparing by doses, you can see this was a very large study done all over the world, that the pasireotide lower dose in patients that have been uncontrolled before, controlled more patients, the same thing with the pasireotide higher dose, and this was GH compared with the active control. So these were patients that have been uncontrolled with octreotide or lanreotide. So we can expect another 25% reduction in growth hormone IGF-1. So this is not a solution for everybody, but might be a little bit better for some patients, and it's associated with significant tumor volume reduction. However, as you heard earlier, every medication has complications, but the hyperglycemia was seen in the large majority of patients. Keep in mind, half overall did not develop, but a lot of them develop. So once we start this medication, we have to make sure it's the right patient to start with, and then we closely do the follow-up. And now we move to the growth hormone receptor antagonist, pegvisomant, that it has been approved for many years right now. The initial study showed very high normalization, up to 97%. However, all the real-life data was 63%. We recently presented the longest follow-up at Endo in a poster this year. It's not published yet, but it's about the same. If you're looking over the years, for patients here on the left, you have the patients that normalize, and on the right, the patients that not normalize. Look at the dose. The dose was not much higher in patients that did not normalize. So the lack of up-titration of the dose is probably one of the causes for these results. And I didn't mention, but clearly in the study that I showed you earlier, the lack of up-titration for octreotide, lanreotide, or pasireotide, I'm sure played a role. Now, the same thing, looking at predictors, I will be happy to answer more questions, but the low IGF-1 at baseline and no diabetes predicted better control for patients to pegvisomant in multiple studies. I'm not going to go in all details, but I'm going to just briefly discuss that there are several new drugs currently in development, so there is hope that we'll find every time better drugs or better administration overall. The oral octreotide, one phase 3 was published, one ended in enrollment, and one is in progress. The octreotide depot, it's a ready-to-use formulation of octreotide injections. That's a phase 2, a longer acting that we have right now that you have to inject 3 times a day. Another somatostatin receptor ligand with preferential binding also to 4 that might have better diabetes effects, or non-diabetes, actually, it's in a phase 2. It's an orally bioavailable SST2 selective non-peptide somatostatin biased agonist. There are 2 phase 2 studies in progress from Crinetics. And then also the Ionis has an antisense LICA generation drug that the phase 2 studies in progress all over the world. And you can find details on clinicaltrials.gov on all these drugs that I have talked to you about and the design of the study. There are no results yet. The studies are in progress. And why it's important to think about, as I said initially, before we're wrapping up, is the type of treatment is very important. And you heard about surgery. I showed you the medications. We're not going to discuss the radiation data in detail, and sometimes we need it, especially in our center and in US overall, it's third line. But some patients grow despite everything that we do. But we're thinking about which is the right patient to have any type of therapy. And this was a very interesting study comparing data between Bulgaria in Eastern Europe and Italy. And if we're looking at the disease control in this study, Italy was much higher. And if we're looking at what medications that we're using, they are clearly using more medications in Italy and more radiation in Bulgaria. So if we're looking at the comparison, the patients with that had radiation and they were not controlled, so this is not just radiation overall, They had higher mortality in Bulgaria, comparing with the Italian cohort that the standard mortality ratio returned basically to normal population overall. We also get more and more questions and several emails probably per month from patients that are asking about how can we treat acromegaly in pregnancy? And the short answer is it's very, very complicated, and we don't know, and we don't have any prospective data, and we're not going to have any prospective data because patients with that are pregnant, none of these drugs are actually approved. So what we do right now, we stop the medical treatment at conception. And there have been several retrospective or observational studies showing that if we use them up to conceptions, there are no links to adverse fetal outcomes. And if clinically needed, but half of the patients don't need it because the placenta has direct effects on growth hormone resistance, so they might normalize their IGF-1 even without medication. But if we need it, though not approved, theoretically in selected cases, all the drugs have been started during pregnancy with no particular adverse effects noted. There were some higher risks overall of smaller baby or larger babies, but not significantly higher compared with the risk overall. That being said, a pregnant patient with acromegaly requires, in my opinion and per guidelines, specialized care and needs to be seen in a tertiary center overall. So which are the clinical challenges? We showed you that the optimal timing intervals for follow-up is not really known. If you are going to ask some questions about what to do when the growth hormone is discordant from IGF-1, I have not covered that, but it's about 30% of cases, so it's not just you that you're asking. There are many, many patients that have that, and that depends on clinical situation. The complications of screening and management, you heard from Dr. Varlamov, excellent presentation, how we should do it and how we're struggling to actually do it. And these should all be for prevention of loss to follow-up. So overall, we get better outcomes that right now they are in our hands, and with proper treatment, we can treat most of the comorbidities with the exception of the joint pain and arthritis that are still the larger hassle that we still don't know how to treat. Besides actually diagnosing the disease earlier. And all the patients will return mortality-wise, a normal population if we have appropriate treatment. So this is our goal and all our work, and you've seen some of it, but we are committed to take care of all the patients with pituitary disorders that we're seeing and to make sure that we're doing the best. And we love the patient cooperation in that. So with this, I'm stopping, and you have there our email for research, or my email that most of you might have it already, and definitely right now we can turn to questions.
Excellent presentation. Thank you so much. We do have a question from a 50-year-old female. She's been having some symptoms that are making the quality of her life terrible. She was diagnosed in the ER with a microadenoma. The endocrinologist said that she was fine and just going through menopause. Her IGF-1 levels are 287, with the normal range being 57 to 195. They're giving her trigger point injections of steroids every 2 months and said that it may be necessary for the rest of her life. She keeps feeling worse and worse. She's going to be seeing a new endocrinologist and wants to know how to approach the new doctor for him to see if she has acromegaly. And if a patient has elevated IGF-1, is it possible to not have acromegaly?
So thank you for your questions. We cannot answer specifically for this particular patient, but we can talk in general about what happens when you have a small pituitary tumor, symptoms of possible acromegaly, but also not clear in elevated IGF-1. So right now, especially if this patient is from US, there are several laboratories that are using assays that are showing mild elevation in IGF-1 without being acromegaly per se. However, from what you are describing, severe joint pains, presence of a tumor that's not very tiny, this patient definitely, or a patient like this definitely needs to be ruled out. Our approach is to do an IGF-1 in everybody that has a pituitary tumor. So if a patient will go to a new physician, definitely the patient should discuss with the physician the fact that the patient has a pituitary tumor. There are symptoms that the trigger point could be or could not be related, but I'm sure there are a lot of other corollary of symptoms that potentially could be related to acromegaly. And an IGF-1 in a reliable lab might be able to make the diagnosis. Sometimes if it's high normal in a lab and higher in the other one, then the suspicion is higher. And then this is a set of patients that we always do in the absence of diabetes, an oral glucose tolerance test for growth hormone. It might help. It's not a final answer because especially if it's early growth hormone excess with mild elevation in IGF-1, about 30% of patients might have normal OGTT with growth hormone. The flip to that is that if the patient has severe diabetes, the OGTT is not going to be reliable, but definitely a full workup for acromegaly, or potentially that tumor needs a full workup for all the pituitary function. From what you're describing with steroid injections, the steroid axis, the hypothalamic pituitary adrenal axis is going to be hard to be checked just because of the injections per se, but this needs to be looked at later on. And we usually do another MRI in a year if it's a smaller tumor, regardless of the workup.
Okay, excellent. Thank you. You mentioned with medication titration, and that some people who were still having symptoms maybe hadn't been titrated. Can you explain that a little bit?
Definitely. So what I have been saying was that the study that I have shown were not specifically looking at symptoms. I showed other studies for symptoms, but this is a very good point how we actually do it. So in our group, what we do is we titrate up, and have been published about that probably 10 years ago the first time, is we titrate up until we get perfect numbers. And the numbers for that would be IGF-1 somewhere in the middle in general. It's hard to choose exactly in the middle, but sometimes we can do it. And I look at, with the exception of pegvisomant that we can measure GH, we look at both GH and IGF-1 in the same time. Now, if the patient, the numbers are numbers, and we have to treat the patient. So if the patient is having symptoms that potentially are compatible with growth hormone excess, like headache, sweating, still joint pain, then we increase the dose still to keep the IGF-1 normal, but we give another chance to be a little bit lower. However, sometimes we find out that the symptoms were not related to acromegaly because we can fix it directly. Or because headache and sweating usually with increasing dose, you can control it. I said earlier that joint pain is much, much more complicated, and sometimes after destruction of the cartilage, you can't do anything. Now, keep in mind that if we do the IGF-1 much lower, we might be able to fix the headaches, for example, or sometimes sweating, but then the patient basically is almost growth hormone deficient. So we can't do that either because growth hormone deficiency is coming with another corollary of issues overall. So we tried and we do our best to increase the doses, especially for symptoms when we're in the uncontrolled, mildly elevated, or immediately on the high normal. When it's already in the middle, rarely change doses just based on symptoms, unless clearly it's a corollary of several of them.
Okay, thank you. What are the normal ranges for IGF-1? In UK, IGF levels are above 23 are considered abnormal. This is different from the ranges you described. This is important as a diagnosis was made based on levels of 37.
So that's I'm sorry we didn't cover that in detail, that all the units we have used are for US. So it's not, and even for US, it's the normal range of the labs itself. So we are using several labs in Portland area, for example, and each of them had different normals. So what each patient should look would be, and again, the unit itself, that's a different story, are different in US versus Europe, and UK is still in Europe, I guess, for now. But that's why she saw hundreds versus 20s overall as normal, comparing US with UK. But that's a very important point, should be mid-normal of the assay of the lab itself. And also it's very important, and most of the labs in US are doing it right now, would be to assess by age. So should be, there are some differences between sex. Most of the labs are not doing. The oral estrogen can play a role. That's a little bit more complicated, but at least by age should be normal range listed for the lab itself that are significantly different. So a patient in their 20s have a normal IGF-1 that could be almost double that somebody in their 70s, for example.
Do you think there'll ever be a standard across the board with the difference between labs?
Do you want my answer with what I think or what I wish? My wish is yes. It's as frustrating for physicians as it's for doctors. All these labs issues between IGF-1, talking about the cortisol, ACTH, and all that. But if you ask me if I think it's going to be a normal range for everybody, and all the labs would be the same, probably not in my lifetime, maybe Dr. Varlamov's lifetime and career, but I don't think so. I wish.
Okay. Headaches, are they only present due to tumor compression, or GH excess itself can cause headaches?
Yeah, excellent question. GH excess itself can cause headaches. And in some cases, some patients will take additional octreotide subcutaneous 3 times a day in addition to their maintenance treatment to control headaches. Because yes, GH itself can change perception of pain signals that come come from the brain. So very good question. But tumor itself can also cause headaches.
Okay, excellent. Are there any studies looking at medical versus surgical treatment in asymptomatic patients with acromegaly?
So that's a very interesting question, what we're talking about asymptomatic. So if the patient, that depends, and also on the size of the tumor. So there are no studies to answer the direct questions that you heard from this patient. The issue is that there are studies looking at medical therapy as primary medical therapy, that all of them are from Europe, not from US, that some patients do not need to go to surgery. However, keep in mind that in US, the surgery is primary therapy for the large majority of patients. And in addition to that, we need, because most of these tumors are larger. So I think your question would be much better answered in hopefully 10 or 20 years, when we'll have very small tumors with, if we diagnose it earlier, in the large majority of patients. And sometimes we have seen here too, patients that they didn't even know they have any symptoms whatsoever. The tumor was found falling skiing and found on imaging, and the labs showed elevation. Now the cost of this, as you heard from Dr. Cetas, surgery is one time and done. So with the access to an excellent surgeon, though we are neuroendocrinologists, so we like medications, the surgery would work very, very well for a small tumor, even without symptoms. So if it's documented acromegaly or documented hyperfunctioning of the tumor for other things that we're not going now in details, surgery should be the answer for that particular patient. If it's a non-functioning tumor with no symptoms, then it's a different story. Then that depends on the size of the tumor, how we actually answer.
Okay, thank you. Screening for heart issues, sleep apnea, are they only for symptomatic patients?
No, they're for all patients, and that's because many patients don't have symptoms of those specific complications, especially if they're in the early stage of the development, and that's why it's very important to catch them early and prevent the progression. So everybody should get screened, not just older patients, not just patients who have symptoms, but everybody.
Excellent, thank you. I don't see any more questions right now. Oh, wait. Just when I say that, another one pops up. Okay. This one is a little longer. I have a microadenoma. My prolactin is usually level, and last year my IGF-1 was high, 380 something, and nothing is done. I have all the symptoms of acromegaly, headaches, facial feature changes, joint pain for years, separation of my teeth, problem breathing at night, and last month I started having irregular palpitations. In February, the IGF-1 levels dropped to 226, but still having the symptoms, and every day I can't recognize myself when I look in the mirror. My prolactin was tested last week, but my primary doctor said it's high. Don't know how my IGF-1 levels are. Can a small tumor of 3 millimeters be treated just with medication?
So that's a very interesting question overall. Again, it's very, very detailed with patient's data, so we cannot answer specifically for this particular patient. In general, for patients that have a pituitary tumors and many symptoms possible consistent with growth hormone excess, we recommend testing of the pituitary function, including, as it was done in this case, prolactin and IGF-1. If the IGF-1 is high and then another one is high normal, then the patient will require oral glucose tolerance test to look at the GH dynamics. If the symptoms are, as was mentioned, and again, we cannot answer for a particular patient, but if the symptoms of headache, sweating, joint pain, spacing of the teeth are persistent, then more testing has to be done for that particular patient to make sure that the growth hormone excess is not present, and if it's present, it needs to be treated.
And I just wanted to add that not always symptoms correlate with the level of GH and IGF-1. So some patients with somewhat lower levels can have very similar changes to their body and complications as the patients with higher levels. Sometimes it has to do with the duration of the disease, how long they've been exposed to elevated growth hormone, as well as their sensitivity. So there might be some genes that are responsible for lower sensitivity to growth hormone and IGF-1, and genes that make patients more sensitive to the changes. So yes, if there is suspicion for the disease and there are some abnormal labs, then that requires more testing, more follow-up, and treatment once the diagnosis is confirmed.
Thank you. And I'd like to add that find a pituitary specialist who can address these issues and make sure you get the proper testing. Somebody who has experience treating acromegaly will give you a much better outcomes.
Yes, that's a very good point. So in general, especially for complicated patients when the diagnosis is not clear, as I mentioned earlier, in pregnancy, larger tumors, the treatment in a tertiary outcome, in a tertiary center has been shown that will improve outcomes. So definitely the Pituitary Center of Excellence should be the place that the patients are seeing. And there are some in several areas.
Yes, absolutely. Thank you. Medical management. What levels of IGF-1 would you aim for? A percentage drop or drop to normal levels?
Yeah, so normally we aim for IGF-1 level in the mid-normal. That typically results in control of the symptoms. However, some patients will have persistent symptoms, and that's very difficult to ascertain whether that's due to IGF-1, GH, or due to something else. So in some cases, we will continue to increase the dose to target lower IGF-1 levels. But again, the caveat is that we don't want to make the patient growth hormone deficient, because that can also lead to certain symptoms and health problems. So in general, yes, it's the IGF-1 level that we use to track, to control whether the disease is controlled. But we also measure growth hormone level, ideally should be fasting in the morning. But that also gives us an idea of where the patient is. In the past, GH has been used a lot to determine whether it's controlled, but more recently we use IGF-1 and in combination with growth hormone.
Excellent, thank you. A couple of messages thanking you all for your presentation. It was excellent. Always learn so much with these webinars. I don't see any more questions, so we are going to wrap it up.
Thank you so much. It was our pleasure. And if anyone that will listen to the webinar has additional questions, we'll be happy to answer them.
Excellent. Thank you so much. More thank yous.
Thank you so much.
Excellent presentation. It was wonderful. We even have people watching from the UK, so that's excellent. This concludes today's webinar presentation. We appreciate you all taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family or friends, it will be available on our website, www.pituitary.org, after it's edited. There will be a brief survey after the webinar. Please fill it out to help us get you the information that you're looking for. Thank you for joining us, and everybody enjoy the rest of your day.
Thank you so much, Tammy, for your help through that, and thank you, PNA, for doing the webinar to discuss with the patients. Thank you.
Yes, and thank you for an excellent presentation, as always.
Thank you.
Thanks.
Thank you.